So as a content creator, the worst thing that could possibly happen to you is you recording a video and then there's no audio that's coming from your microphone. And I actually recorded this lecture, and when I played it back, the audio was quite horrible and I couldn't do anything about it. So I have to re-record this particular lecture. I've had this in the works for quite some time. So after that, I wanted to record this video because we have a lot of schools that are mushrooming up. And I know that this is part of the curriculum, especially for those that are doing MBCHP, even those doing MBBS. Medical ethics is very important for you to actually learn. But we sort of overlook. I think this is something that is quite overlooked even in medical school at so many different levels. So I wanted to actually do a lecture on medical ethics. This is some sort of introduction of some sorts. If you guys are interested in this content, please show some support, drop a like, and drop a comment so that I can keep making such amazing content. Grab your piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at medical ethics. This is an introduction of some sorts. So just off the bat, I want to give you a clinical scenario. Suppose you are working at a certain hospital, and let's say you come into that particular hospital and you are hungry that particular day. You haven't eaten any single thing, then you start doing your ward round. You see a patient that you're about to discharge, and then as you discharge this patient, the patient just calls you to the side and is like, oh, you really helped us. Your attitude was very good. He gives you a 400 kwacha. Here's something for lunch. What are you going to do with that money? Are you going to give that money back to the patient and decline? Are you going to take the money and go buy lunch secretly because you've worked hard for it? Are you going to take the money, give it to your supervisor? Are you going to take the money, give it to the hospital? Are you going to take the money and give it to the nurses? What are you going to do with that money? I am interested in finding out what you guys think. So please comment in the comment section below, because this scenario hinges on ethics and it happens quite a lot of times on the ward. Now, before we actually get into details of this particular lecture, I want this to be sort of like a talk, something that is interactive. So there should be a bit of some interaction. Now, I've added a lot of interesting cases to this particular talk. So by the time you go through it, you should be able to understand every single thing. So when you graduate as a doctor and you get into the profession, there is something that's known as the Hippocrates Oath that you're going to be taking. This is actually one of the earliest documents in medical ethics. It's somewhere around the 5th century BC. And all doctors that are actually getting into the profession are going to be reciting the Hippocrates Oath to some extent. So it's going to be considered as something that is sacred, and it's going to have some religious foundation and sanctity. I won't go into details of the Hippocrates Oath because I think it's a video that I should do on my other channel. By the way, if you haven't subscribed to that channel, I don't know what you're waiting for. Please head over there and subscribe. There'll be more content coming up on that particular channel as well. So getting into medical ethics, remember that most of the terms that are coming in medicine are either coming from Latin or they're coming from Greek. So if you look at the term etiquette, which is a Greek word to mean a habit, an action, or character. So simply put, these are going to be these philosophical principles that are going to guide you on what is right and what is wrong in context in the hospital, how you're going to be dealing with other colleagues, not just doctors, but even nurses, even the pharmacists, the auxiliary staff in the hospital, how you're going to be dealing with patients, how you're going to be dealing with your subordinates, how you're going to be dealing with your superiors. So when you talk about medical ethics, they're just simply these moral principles for all the registered medical practitioners that are going to be helping with their dealings with each other, with the patients, and even with the states. So remember that when we talk about medical ethics, it's more or less very specific because this is things that are going to be in relation to the medical practice. It's very different from biomedical ethics or bioethics because that's going to be a much broader term that's going to be referring to other different things. Because remember that the things that are affecting medicine are much, much wider than just patients and people. You have research that's being carried on. You have the biological engineering that's going on. So the principles that govern those things fall under the bracket of medical or bioethical principles. That's not what we're going to be focusing in this particular lecture. So remember that sometimes there are certain things that you're going to be required to do that are recommended by the law that may not go so well with your ethics. So remember that the law and ethics are usually closely related many times. But when you look at which one requires you to have a higher standard, most of the times you find out that ethics actually require you to have a higher standard of behavior compared to the law. There are some places and there are some countries and states which believe in certain things. Like, for example, countries that believe in mercy killing, euthanasia. Zambia is not one of them. But the Netherlands, the Belgium also believe in euthanasia, which is mercy killing. So now, remember that one of the core principles of you as a doctor is to do no harm. So you assisting that person kill themselves, maybe because they have a condition that cannot allow them to sustain themselves, and they may be on a machine, they're on a vent, and then you kill them. You assist in killing them, or rather assist in taking their life. That's a much better term to use. That's going against your ethical principles. But according to the law has provisions for that in those countries. But if you do that in another country, that's going to be deemed as morally unethical. And of course, it's going to be dealt as a crime because it's not legal in Zambia, for example. So there are other scenarios that may create such similar conflicts between the law and ethics. For example, those that are participating in execution, when you find a murderer, for example, and he's sentenced to death, then you as a practitioner, you're the one who's going to be administering that medication to kill that patient. It's a concoction of different drugs. So remember, your fundamental principle as a doctor is to do no harm, but then you're going to be causing harm in this particular patient. So remember that, again, you may have some reporting laws that may breach confidentiality. Remember that there's some sort of trust that is going to be happening between the doctor and the patient. If the patient tells you certain things like, okay, I'm confiding this information in you, it means that you should have that courtesy to keep that information private, such that the only people that are privileged to that information are those that are dealing with the case, other healthcare workers dealing with the case, other colleague doctors that are dealing with the case, other clinicians that are dealing with the case. But if it's in a case where someone tells you something that is related, for example, to a crime, an unsolved murder, for example, then you have to report that to the officials because, again, the law in this case is going to supersede your ethical principles, your principles of confidentiality. So remember that there are certain things, there are certain principles of ethics that are going to be overridden based on certain circumstances. For example, someone tells you that they killed another person, and they tell you exactly where they buried the body. If that person is of the same mind, and you take that seriously, you should actually inform the authorities and pass that information regardless of that principle of confidentiality being breached. So there is something that's known as a medical etiquette. And remember that in terms of medical etiquette, it's not just to our colleagues. It's what is actually going to be these conventional laws and customs of courtesy and even code of conduct that are going to be helping relationships between the physician with colleagues, but also with the physician and the patient. There's professional conduct that is going to be there, even courtesy to the patients. Remember, when you go see a patient for the first time, you're supposed to greet that patient, you're supposed to introduce yourself, you're supposed to be formal with that patient. We shouldn't see a particular place or a particular scenario where there is this informal or the patient feels disrespected. Every patient must be respected. And remember, I made a social media post this past week, and it got a lot of reactions from most of the healthcare workers that are following my page. And the post was literally in the sense that if healthcare workers were actually given a chance to talk back to the patients, then I really want to see what would happen. And a lot of people are carrying a lot of things. Yeah. So the sense of that is that we don't want to be talking back to the patient necessarily. The whole goal is that you want to respond in a respectful manner to the patient. You want to have a respectful conversation. It's not a fight. The patient is not coming to the hospital to fight you, neither are you there to fight the patient. So generally, there should be some sort of respect and some sort of courtesy that is offered between the clinician that is seeing the patient and even the one that is the patient themselves towards the clinician. Then you also have some sort of medical etiquette towards other auxiliary staff, towards colleagues, towards those that are your supervisors, towards those that are your subordinates. Now, in terms of the hospital setting, as you know, there are many different cadres that are going to be there working in the hospital. You have nurses, you have clinicians, you have doctors, you have lab tech, you have the phlebotomists, you have the auxiliary staff like the cleaners, the porters. All those are important. Every single person must be treated with respect because every single person has some sort of contribution towards your welfare, has some sort of contribution towards the patient's welfare, and of course towards keeping the environment safe and keeping the environment conducive. Bear in mind, for example, if you have a cleaner, the cleaner just decides to stop, the environment will become quite dirty. And remember that our infection prevention would have failed at that particular point. So it means that once your infection prevention has failed in that particular point, then it makes it very, very difficult for your infections to be curbed, and infections will spread much, much easier. Then, of course, there should be some way in which you should conduct yourself. You should be dressed quite well. You can't be a doctor and come with ripped jeans. You can't be a doctor and come in a miniskirt. You should be presentable. Even you can't be a doctor, come in unkempt. You come unkempt to the hospital. You should actually present yourself in the most visible and the most sane manner that you're going to be actually coming in with. And of course, when you're addressing your supervisors, every time your supervisor walks into the room and you're seated, you always have to stand up. Medicine is you can think of medicine sort of like military. When there's a military and someone with a higher rank actually comes to the hospital, you have to stand, or rather you have to salute them if you are, wherever you are. Same thing with medicine. There is this etiquette that is there. When your boss walks in and you're seated, you stand up until your boss tells you to sit. If you're in a meeting and you're the most junior person that's there and the senior walks in, you are the one who has to stand up and offer them a chair. Unless if it is your boss that actually offered you the chair to sit down and then they themselves stand, and that's okay. We refer to that as medical etiquette. These things actually are not really emphasized in school, and we can see that a lot of this has been lost. We see a lot of people talking back to the bosses, talking back to supervisors, getting into altercations with supervisors. Of course, there's a channel of command. I'll do some future videos to explain a bit of this channel of command and about medical etiquette. So if you're really interested, continue showing some support to this particular content. So why are medical ethics very important for us to learn? Remember that these are going to be governing the relationships between the physician and the patient. They're going to foster respect. They're going to foster informed consent, even confidentiality. It helps even with your patient care, because if your patient doesn't feel respected, they will definitely not take whatever, or they will not listen to whatever information that you have to offer your whatever, regardless of whatever you say. Then it also helps with interactions with colleagues. And remember that with this interaction with colleagues, like I already emphasized for the previous slide, everyone in the particular hospital is important. Everyone has a role to play. It also guides research and research conduct. There are certain things that we can't do. For example, we want to investigate the effect of smoking on lung cancer. You can't develop a trial and say, okay, let's get 20 people and get them to smoke for 20 years and see who develops lung cancer and who doesn't. That's unethical because you're going to be causing disease. Another example I can think about is the Tuskegee experiment, where folks that were infected with syphilis were not given antibiotics, it were given placebos, and they were studying how syphilis actually progressed. That's why syphilis is one of the conditions that we know very well in terms of the progress. But that was unethical when you think about it. So ethics will actually help you guide research conduct. So there are certain principles that we'll look at. I have put them as the ABCs, not airway, breathing, and circulation, but rather autonomy, beneficence, confidentiality, do no harm, equity, or justice. And I will give some pertinent examples for each of these principles of medical ethics. and you should be able to discuss them. I'll give you some key pointers, but I want the discussion to continue in the comment section below because I want to hear what exactly you are thinking. So we'll begin with autonomy. So you have the right to choose. If they offer treatment to you, for example, you come in and you want to go for a particular surgery. For example, you have an appendicitis and you want to get it removed. There are two possible procedures that can be done. There is a laparoscopic type of procedure where they make a small keyhole incision to minimal invasive. Healing time is very good and all that. And then there's another procedure, which is the open method, where they open you up, remove the appendix and close you up, open abdominal surgery. It takes a bit longer. There's a higher risk of blood loss, but for sure, they'll remove the appendix. Both procedures can be done. Both procedures have been successful. When you now come in with appendicitis, these two procedures will be offered, depending on whether the facility has the equipment available, whether the facility has the right trained people available. These procedures must be offered to you. And the doctor must explain the risks, the benefits, the likelihood of success, and any alternative procedure that can be done, which means that for autonomy to actually happen, you as a clinician should be well versed concerning that particular medical condition. You cannot say that the patient made an autonomous decision if you are not well versed with that particular condition. If you as a doctor, you as a clinician have no idea of the different types of operations that you can carry out, and then you want to offer them to a patient, you won't give them adequate information. So you can either find someone that can give them that information, or you can research through that information and offer a much better stance and a much better answer to this particular patient. Because for a patient to actually have autonomy, remember that autonomy is this freedom of thought, freedom of intention, freedom of actions, and even being able to make decisions that are regarding a healthcare procedure. So remember that this must be fully informed consent. They must be fully informed consent. You can't take a patient to theater. You can't do a particular procedure if the patient is not fully informed about the procedure, the complications, the risk of doing the procedure, the risk of not doing the procedure, the likelihood that the procedure will be successful, any alternative procedures that can be done, and how do they compare with each other. The patient must understand these. And remember that you must avoid jargon. So you must explain this as clearly as possible to the patient, such that even they can explain it to their relatives, they can explain it themselves to anyone who asks. That's the first prerequisite that must be there if autonomy should be respected. The second is someone must be of a correct state of mind. They must be of a sound mind. What do I mean? Someone coming in and they are acutely confused, they are delirious, and they tell you that I don't want this particular treatment. In that case, you can't respect the autonomy because this person is not in the right state of mind to make such decisions. In such a place now, that is when you have to wait for their next of kin or the person who has legal guardianship over this particular person. And that's the person that's going to be making the decisions for this particular person, whoever that they have deemed legally to be able to make their decisions if they are not fit. Of course, it's a bit different in terms of people that come in an accident and those that come in an emergency. It's a bit different. Then the legal age is also another prerequisite that needs to be met. So remember that people that are underage cannot make decisions. For example, you can't make a decision that I need surgery, but you're underage. Your parents need to make that decision. This now creates a bit of a problem because in some cases, in some places, the child may need a particular procedure that is life-saving, and the parents actually deny the child from getting that procedure, maybe because of beliefs or whatever it may be. In that case, it's a bit tricky, but there are ways in which you can actually circumvent this. I will discuss it as the lecture goes on. So remember that once you have now offered these three things, then autonomy and the patient's decision must be respected. And remember, you as a physician, your duty in all this is for you to tell the truth. Remember that it's very easy to actually counsel a patient towards accepting a procedure versus towards denying a certain procedure. Very easy to counsel them that way. It's very easy to manipulate people, but that's what you shouldn't do. So there should be some sort of veracity, which is the ability to tell the truth, and there should be fidelity. You must follow through with your commitments. If you say you're going to do this particular procedure, let it be done the way you have explained to the patient how this procedure is going to be done. So here's case one. So Kayla, a 22-year-old medical student, presents to your outpatient clinic requesting a medical abortion. She is 8 weeks pregnant, emotionally composed, and clear in her decision. Very important to keep in mind. She explains that continuing the pregnancy would jeopardize her education, financial stability, and mental health. She has researched her options and meets the criteria for safe termination under Zambia's legal provisions, e.g., risk of mental health, even education disruption. By the way, just let's digress a bit. In Zambia, the laws of abortion are rather a bit strict in which the scenarios in which abortion can actually happen. I'll explain them in the next slide. However, the attending clinician hesitates. He believes that abortion is morally wrong, and he insists that she must first obtain consent from her parents and a psychologist, even though the law does not require this for competent adults. He delays the process, hoping she will reconsider. Kayla becomes distressed, feeling judged and obstructed. She asks to speak with you directly, knowing you advocated for respectful and patient-centered care. Very, very practical scenario because a lot of patients will come to see you. I'll leave this lecture in all the specialties, internal medicine, surgery, pediatrics, obstetrics, because there are scenarios for each and every single part of the department. So this one here is for obstetrics and gynecology. Someone has coming in and they want to terminate their pregnancy. Remember that in terms of abortion, abortion is legal only under certain circumstances. And there are certain things that have to be filled out. There are certain forms that have to be filled out. There are certain paperwork that has to be filled out. I did a video on the laws of abortion in Zambia way back. You can check it up in the Obs and Gyn playlist. But here's an overview of that particular video. So abortion is legal under certain circumstances. Number one, the circumstances in which abortion can be legal in our particular country is number one, if the mother's life is at danger. For example, if there's risk of mortality in the mother, the risk of mortality is greater than the risk of carrying this pregnancy on. For example, women that come in with severe preeclampsia, women that come in with eclampsia, for example. Or if there's a risk to the mother's health status, emotional and social economic status, then that's another indication why this woman could possibly get an abortion. Then the other scenario where an abortion is actually legal is if this child has a condition that is not compatible with life, or this child has a severe deformity such that it would make the quality of life rather impossible. This child would be born with a significant birth defect. In that case, or if there's a jeopardy to both the mother and the fetus, in those cases, abortions would be considered as legal. And in these particular cases, you need input also from other people. These other three people must be of good standing. One of them must be a specialist in that particular field, but must not be involved in the case. And then two other people of good standing. So three separate doctors, aside you who's going to carry out the procedure, need to sign off from that procedure for it to actually be considered as legal. If this doesn't happen, big problem. Now you ask, what about the emergencies that we have? In an emergency setup, you just need one physician of good standing. And remember, your primary goal is to save lives, to do no harm. So if someone comes in, they have a septic abortion, you're not going to say abortion is legal, so let's not help this particular patient. No, that's not the problem. But remember that if they have done it in a dubious manner, then you are actually put in a very tight position, because according to the law, abortion is, if they've done it and they have no particular reason, this paperwork is not filled up, then that becomes illegal. You are actually mandated by the law to actually report this. So now, what are the questions pertaining this case? What does autonomy require in this case? Are additional consents ethically or legally justified? How should clinicians navigate personal beliefs in ethical charged situations? What safeguards ensure that the patients are not coerced or even delayed? How can the system support respect for abortion and care while honoring the diverse values? Very important talking points to actually think about. Just pause the video, write down whatever you think. I will give you a bit of some discussion points that will point you towards the right direction. I will not give you the answer because I want the discussion to actually continue in the comment section below. So remember that according to this case, Autonomy is going to demand that you actually respect her decision because number one, it's informed. Number two, she's above the legal age. Number three, it's a voluntary decision. She knows the repercussions of this pregnancy. So, according to autonomy, you are tied to that. But then beneficence and non-maleficence also support that you should offer this patient safe and timely care. Because if you don't offer this woman the abortion, either way, she's going to find a way to actually get it. With the way life is advancing, a lot of these pharmacies are popping up. It's very easy to find these medications anyhow. She's obviously going to do what's stopping her from researching home remedies to get rid of a pregnancy, for example. Then justice is going to warn you against imposing unnecessary barriers based on personal bias. For example, you, because you're a Christian and you're deputy Jesus, and you say that, okay, abortion is illegal, so abortion is not morally correct, so no one should get an abortion. No. Remember that when you come into medicine and you're treating patients, you put aside your personal biases. You'll be forced sometimes to do certain things that go against your own beliefs. So you shouldn't force or impose your beliefs on other people. It's ethically wrong. You know, of course, professional integrity will require you as a clinician to act within the legal and ethical bounds, even when your personal beliefs are conflicted. I think I already talked about this. We move now to beneficence, which is where now the patient should benefit. You want to act in the best interests of the patient. So you want to provide certain treatment, provide certain procedures, and these are done with good intention for this particular patient. So you're keeping in mind the patient's welfare. Let's look at a clinical scenario. So Joseph, a 45-year-old Jehovah's Witness, is admitted to the emergency unit with severe upper GI bleeding, likely from esophageal varices. You can already see where this is going. His hemoglobin is 5.2 and he's hypotensive despite fluid resuscitation. Endoscopy is planned, but he urgently needs a transfusion to survive the procedure. He is alert and competent. When you explain the need for blood, he calmly refuses, citing his religious beliefs. He hands you a signed advance directive stating no blood products or blood under any circumstances. His wife, visibly distressed, pleads with you privately, please, just give him blood. He's a father. He's scared. He'll forgive you later. You know that without transfusion, his chances of surviving the bleed and the procedure is slim. You also know that violating his directive could cause deep spiritual and emotional harm, even if it saves his life. What are you going to do in this particular scenario? Remember that this, again, a patient is, number one, is above legal age. Number two, he's not confused, so he is of sound mind. He's competent, he's alert and he's competent, and he's autonomous. He has said that, I don't want blood. But you as a doctor, you know that you want to act in the interest of the patient. So you know that in the interest of the patient, this patient needs banding. But before the banding can be done, you know that this patient actually requires blood because for him to survive the procedure and for him to survive the GI bleeding, he actually needs blood. But this is a patient that has actually declined that. So this is a very precarious position, and we find ourselves a lot of times in this position, especially if you're working in the internal medicine department. So can beneficence override a competent patient's refusal of life-saving care? What are you going to do in this particular case? Are you going to withdraw care? Or are you going to use certain alternatives? And we found ourselves in such a situation. I remember dealing with such a patient where there was this woman that was referred from a local facility. She was referred in shock. So this woman, I think they did an HB, a full blood count, and the HB was somewhere around 3. And the patient was already loaded with fluids, so this patient was already hemodiluted. So when the patient came in, the patient was still in shock, so we decided to start the inotropic support as we pushed for blood. I even mentioned that this patient needs blood. So when she heard that, she was like, no, I can't receive blood because I'm Jehovah's Witness. So that's how, like, oh no, you need to sign in the file, otherwise these are legal issues and we may be held accountable if this person actually doesn't, if she doesn't make it. So just before they could sign, that's how she deteriorated. We started resuscitating the patient. That's how the patient ended up dying. Now, this is a woman that was of sane mind. She was competent. She was above the legal age of decision. And she understood the risks because we told her that this woman is going to die. If she doesn't get blood, This woman is going to die. She won't make it. She's in shock. She needs blood. We can't keep giving her more IV fluids. So in this case, it's very difficult to actually override, because in an event that we override the patient's beneficence, or rather we override the patient's autonomy and they are of sane mind, they could actually forcibly sue you. In this particular case, they'll possibly sue you because they'll say that, no, I didn't want this. And of course, you have caused some sort of emotional damage to this particular patient by giving them the blood, because that goes against their belief. That contradicts their belief. So is now balancing between medical urgency and spiritual integrity. That's a very difficult thing to do, because again, in short, you're simply asking the patient to get rid of their beliefs, which is something that is very, very difficult to do. So what alternatives exist? Of course, these again, that they are available are only temporary measures, will only be a stopgap. It's like you have a huge defect in a water tank and you just put a bit of some duct tape. The leak will still be coming out, but you're just buying yourself time for something bigger that's going to happen. So plasma expanders are an option. I remember giving a lot of these patients that don't want blood some plasma expanders. Iron and erythropoietin take a very long time to work. About a week or so for them to begin to work, because remember the synthesis of red blood cells takes a long time. So you need to explain all these things to the patient so that they actually understand what is going on. And then of course, how do you support the family while respecting the patient's wishes? Again, this is very important. It ties in with the next question, is what documentation and communication strategies protect both the patient and the clinician? Because remember, you should protect your patients. You should also protect yourself, because your job is at risk. If this patient dies and the relatives take you to court and say, no, why didn't you transfuse our relative? Our relative has died, but you could have saved our relative because of the transfusion. In medicine, if something is not documented, it's not done. So if you say that, oh, I did this, but you have never documented, there's no way you can prove that you have done this thing, then you can consider that as not done, because no one's going to hear your hearsays in court when you go to court. So remember that in terms of this particular case, you would want to document every single thing. And when you're documenting and they're signing in the file, especially when they refuse a specific treatment, it must involve they themselves, a relative, a witness who's a relative witness, and also a witness who's part of your staff. For example, a nurse or even another doctor colleague must be present. And when they're writing in the file, they must write that such and such procedure has been offered, but we have declined because of such and such reasons, because of religious beliefs, for example. And we have opted for something else. They document whatever they have opted for, then the patient should sign. And if the patient signs, that other person who's a witness should also sign. Then your witness, the other colleague, the other worker must also sign, and you yourself must sign and add a date to that. Just that if anything adverse actually happens, then you're able to protect yourself and you'll be able to go back to the documentation and say this patient actually declined this and it was offered. So remember that in terms of beneficence, it will urge you to save Joseph's life with the best available treatment, but then autonomy will demand that you should respect his decision. He has informed you that he doesn't want this, so even if it causes him to die, respect that. Then in terms of non-maleficence, it will warn against causing spiritual or psychological harm through unwanted intervention. If someone doesn't want something and we give them, even if it has saved their lives, even if it's good for them, patients are very weird. They'll be super upset with you. They'll take you to court. And of course, in terms of justice, it will remind you that to treat all patients with equal respect and regardless of their belief. So case 3, I won't discuss it so much. I just want to leave it out here for you guys to talk about in the comment section below. A 52-year-old farmer from the rural district presents to your GIT unit with signs of peritonitis. He's hypotensive, febrile, has rebound tenderness. Imaging confirms a perforated duodenal ulcer. He requires urgent surgical intervention. However, the hospital policy mandates upfront payment for non-emergency surgeries unless the patient is enrolled in a national health insurance scheme, which is NEMA in our case here, which he is not. The family only affords basic antibiotics and IV fluids. You are the attending clinician on call. The surgical team is willing to operate, but the administration insists on payment clearance. The patient is rapidly deteriorating. What are you going to do in this particular case? With this here, it's often we rarely find our patients in such scenarios here, because when they come into our facility, they were made local policy, and big ups to the Ministry of Health, big ups to the governments. the government, because we have made proper strides in that when patients come into the hospital where I practice, when they come in an emergency, they won't pay a single thing. The test that we'll do for them in that particular emergency will be free. The bed space that we offer them will be free. Opening a file for them will be free because they've come in as an emergency. Because we know that if we now wait for this bureaucratic paperwork to actually happen, it's actually going to delay the care. And once the care has been delayed, the mortality is going to be much higher. But the story is different for those that are actually stable, because we often urge them to actually pass through the clinic where they can be referred to a higher facility if the problem can't be solved at the clinic or at a lower level facility. So the question is to keep in mind, what does beneficence require in this case? Can you ethically override the institutional policy to save a life? How would you document and justify your decision? What system level advocacy could prevent this dilemma in future? In our case here, we're already making strides towards preventing such things. Case number 4. A 34-year-old woman presents with severe fluid overload, uremic encephalopathy, and hyperkalemia secondary to end-stage renal disease. She is a single mother of 3, previously lost to follow-up due to transport costs and lack of family support. She now requires urgent dialysis. Your unit has only 1 dialysis slot available today, and 2 patients are competing for it. The woman who is critically ill and has no financial support, a 65-year-old man with diabetic nephropathy, stable vitals, and was scheduled for routine dialysis. The older man has already paid and arrived early. The younger woman is deteriorating rapidly but has no funds and no crier or key. So this is a very, very important case to actually think about. The reason why it's a very important case to actually think about is patients actually don't know how triage systems actually work in the hospital. They believe that if I got here first, you must see me first. And that's not always the case. Unless if your case is an emergency. But remember that there are some emergencies that are more emergencies than other emergencies. That's a mouthful of words. What do I mean? You yourself can think of your condition as an emergency, and for sure, it will be an emergency to you. You come in and you're acutely distressed, you're acutely vulnerable, and you need this help. But there are other cases which are maybe much more severe. For example, you come in with epigastric pain, maybe some dyspepsia, and that's been happening for maybe the past 2 hours. Then someone comes in and they come in and they're in shock. They were having upper GI bleeding. Of course, you're going to attend to the patient who has upper GI bleeding first, regardless of whether you have paid, whether you are high cost or whatever, because this person, if they're not offered help, they're going to die. But then it makes it a bit tricky, because this person here, this I presume is a paying facility. This person has gone to a paying facility and they have paid. They are entitled to that particular service. Now, why should they wait for someone else? Meanwhile, they also need that particular service. So this creates a lot of problems for us ethically. So should clinical urgency override scheduled care? This, again, we've made strides against this in our local facilities. We actually see the patients that are unstable first, than those that are stable. How do we weigh social vulnerability and triage decisions? Very important. What systems could prevent this ethical bottleneck? We've already made strides in preventing this. And how would you explain your decision to both families? This is very difficult to explain, because how do you explain that we've cut you off because this other person needs it more? They'll also argue in a way. So generally, remember that beneficence will urge you to prioritize the patient in greatest need, which is that woman that's critically ill. But justice will demand that she is fair and transparent allocation of the limited resources. Whoever came first must actually have the treatment first. Then autonomy is limited here because the patients don't understand how the severity of their conditions and they can't advocate for themselves. And non-maleficence will warn you against delaying any care for either of the patients. Moving on to confidentiality, remember that this is based on loyalty and trust. And the confidentiality must be maintained at all times. You mustn't be walking the corridors and speaking about patients, referring to their names, speaking of them in elevators. Avoid that type of behavior. It's unethical behavior. Avoid posting pictures of patients on social media. Avoid posting pictures of operations on social media. That's unethical to actually do, and you're not supposed to do that. So you should maintain confidentiality at all times in terms of personal, medical, and even treatment information. If you actually leak this information or you publicize this information, you're liable to answering and you could possibly get sued. So the information should only be revealed when it's in the benefit of the patient. For example, you're handing over information to another colleague that's coming in to shift, or when you're ethically or legally required. For example, in a criminal proceeding, for example, in a rape case, where now you have to testify, then you actually have to divulge this information to the relevant people. Here's case number 5. You are reviewing a patient you're reviewing patients in the outpatient HIV clinic. A 29-year-old woman by the name of Grace has just tested HIV positive during a routine antenatal screen. She is shocked and tearful and confides that she has never had another partner besides her husband, Daniel. She begs you not to tell him, fearing violence and abandonment. Later that afternoon, Daniel arrives for his scheduled appointment. He is HIV negative and asks confidently, "My wife came earlier today. I'm sure she's negative too, right?" You know he's planning to travel for work and has asked for pre-exposure prophylaxis just in case. He insists on knowing her status before deciding. A discordant couple. This scenario, very common in the hospital. You're going to see it quite a lot of times. Sometimes it's the other way around. The husband turns out to be positive, the wife is negative, and the husband tells you, "Don't tell my wife." What are you going to do in that particular case? Even in this particular case, what are you going to do? What are some of the things you should think about? Can you ethically withhold Grace's status from her husband? Keeping in mind that, remember, your primary goal is to do no harm. If you withhold the status, you're going to be causing harm to the husband. At the same time, if you disclose the status of this woman to the husband, you're going to be causing harm to the wife because she's possibly could be abused, or there could be some abandonment that may be there from the husband. What strategies will you use to encourage a voluntary disclosure? How do you assess and mitigate the risk of intimate partner violence? Should PrEP be offered without full disclosure? Because again, it means that if you give this person PrEP inadvertently, you have answered his question. It means that this person here and this other person may have tested positive. So what does the Zambian law and local policies say about partner notification? Very interested to hear from you guys about these particular questions. Do not forget to show some support in the comment section below. Hit the subscribe button if you haven't subscribed. What are you waiting for? You're busy watching. Yes, I'm talking to you. You're busy watching the video and you haven't subscribed. Shame on you. Anyways, so remember that confidentiality in this case will oblige you to protect Grace's private information, while as beneficence and non-maleficence will urge you to prevent harm, do no harm. So both Daniel, because he's at risk of HIV exposure, and Grace, because she's at risk of domestic violence. But autonomy is challenged. Here, Daniel wants to make an informed decision whether he should receive PrEP or not, and Grace fears the disclosure. So you're put into a very precarious position in this particular places. So I want to hear what you're going to do. And in terms of D, second last, is do no harm. This is non-maleficence. Above all, remember, do no harm. But sometimes it may be something that is known as a double effect, where, for example, an intervention that you're instituting in an attempt to help a patient may also be inadvertently causing harm to the patient. For example, someone has a malignancy, they have a cancer, you want to ease their pain, you want to give them some morphine. You know that morphine will help with the pain, but at the same time, it causes respiratory depression, quickens their road towards mortality. So we refer to that as a double effect. So you actually make sure that the procedures you do not cause any harm to the patients. Case 6. A 17-year-old girl, Miriam, presents to a rural clinic with lower abdominal pain, fever, and vaginal bleeding. On examination, she has signs of sepsis and an incomplete abortion. She eventually confesses to using herbal remedies from a local healer, who I think should be jailed, to terminate a pregnancy. Conceived through coercion by a relative. That got dark really quickly. She is terrified of legal consequences, obviously, and refuses referral to a tertiary hospital. Remember that when someone comes in with an illegal abortion, you are obliged to actually report that. And whoever helped in that abortion must also be reported, because they should also face the law. And they can get up to, at minimum of about 7 years, I can get up to even 14 years imprisonment. Her parents are unaware of the pregnancy and she begs you not to inform them. You know that without surgical evacuation and IV antibiotics, she may not survive. What do you do? This case is a bit different because here autonomy is out of the window. This is a girl who's underage. This is a girl who has been sexually abused by the relative. And of course, she's underage. She's come in with, is doing something that is illegal as well. She's come in, had an abortion, and has now become an incomplete abortion that you need to completely evacuate, possibly a septic rather. Septic, because she's having a fever. So how do you balance non-maleficence with the legal reporting obligations? But remember, in this case, you have to report this case. But in you reporting it, you're causing harm to the patient. What are the ethical duties if abortion was unsafe and illegal? How do you protect the patient from further trauma whilst ensuring that you have medical safety? Because the problem is that the more cases now we begin to report, the more people will fear to come to the hospital. The more they fear to come to the hospital, most of them will be dying from home after taking all these things that they've taken, and they refuse to come to the hospital because they know I'm going to be reported and I'm going to have some jail time. So what system level changes could reduce harm in similar cases? I want you guys to actually talk about these. So remember that in terms of non-maleficence, it is going to urge you to prevent any further harm, both physical and emotional. Beneficence will call for you to save this girl's life. You know that taking that to theater will save the life. But then at the same time, autonomy cannot be made for this girl. She can't be taken to theater because she doesn't meet those 3 criteria. She doesn't meet the legal age, so it means her parents must be involved. But at the same time, you're going to challenge that confidentiality of this particular patient because you have to talk to her parents, because her parents or legal guardian is the one that's supposed to be responsible for signing the consent. Because in an event where you take her to theater minus consent and she dies, you will be sued. The hospital will be sued. In an event you take her to theater and she signs the consent, she's underage, you will be sued. And of course, justice and local law may restrict your options for post-abortal care and reporting. Last but not least is equity or justice. This is fair and equal distribution of scarce health resources in the decision of who gets what treatment. This is where people begin to play God. For example, someone needs treatment outside the country. Here's a committee that sits and decides which patient goes, which patient doesn't. How is it that this other patient is more benefiting, or rather more fitting to receive treatment versus this other patient? More so, remember that this is something that could possibly change their life. So it's a very difficult decision to make, and I would never want to sit on such boards. So remember that the burdens and benefits of new and experimental treatment must be distributed equally, and it must be distributed among all the groups of society. It mustn't be any discrimination. No, because you're a lesbian, this person is lesbian, no treatment for you. Because they are gay, no treatment for you. Because whatever, they're black, no treatment for you. No, that shouldn't be the case. So here's a diagram that I like to explain these 4 terms, because people tend to confuse these 4 terms. Suppose there is a game that is happening and there's a fence that is preventing people from watching the game. So in reality, and this is what happens in reality, you have those people that are very privileged. That's the guy who's on those many crates there seeing the game, is even seeing beyond the stadium. And there's someone who's somewhat privileged, where this person here is barely seeing the game, but they can see the game. Then there's this one who's even, they have dug a hole from him and he can't even see. So he's underprivileged. He's handicapped. Then equality is where everyone now gets the same resources. The one that's tall gets one cardboard box. The one that's medium height, same. The one that's short, the same. We can see that in this particular scenario, the one that's tall can see the game. The one that's medium height is barely seeing the game. The one that's short is not seeing the game. Because, of course, even though they say that life is fair, life shouldn't actually be fair. There should be equity to life. Equity is the 3rd image, where you can see the one that can see the game doesn't need a box. So you don't need to give him a box. The one who's a medium height requires a box, give him a box. The one who's short requires 2 boxes, so they should actually be given 2 boxes. These are the ones that I call the vulnerable groups. But in real life, there should be actually justice, where you remove the fence and such that everyone can watch the game. That's a good way to actually explain these 4 terms. Now, having discussed that, let's talk a little bit about some random things that may help you in terms of ethics. Remember, this is just an introductory class, but we will go through the greater details in other videos if you're really interested in such content. So misconduct could be if there's certain things have been done, for example, violation of certain regulations, are convicted in court, any different types of court. If you're convicted, you're found guilty of the crime, this is misconduct. You could lose your license. If you're signing false professional certificates, reports, and other documents, if any registered practitioner who is shown to have signed or even given under his name and authority any certificate, notification, report, This includes even signals, by the way. Anything that is untrue, misleading, or improper, then you could have your name deleted from the books of grace. The books of grace is what I refer to as the register that we have at our health professional council. You could be deleted from that book. So you could have abuse of doctors' privileges, association with unqualified people. Who talk about that in details later on. Advertising as by canvassing and even improper publicity. Other things that you could do, for example, adultery or improper conduct arising from out of professional relationships, of course. Abortions which are not done in good faith and not according to the law. Abuse of alcohol, indecency, improper relationships with patients, falsifying certificates and degrees, associating with unqualified person, including employment of unqualified people. For example, you have a company, you are employing people that are not fully registered, you're employing people that are not qualified for those particular jobs. You could be held accountable. Advertising in the view of gaining something is wrong. So once you're found guilty of these things, then you could have your practice license actually cancelled or suspended or terminated, meaning that all your time in school would have been wasted. So there is a disciplinary committee, and in our case here, our Health Professions Council of Zambia, HPCZ, is one that's going to be dealing with this. And they publish a code of ethics. If you don't know what this is, then you are practicing playing a very dangerous game. So you make sure that you should read through your code of ethics that is given by HPCZ. Yes, you're qualified. And actually during induction, they give you this code of ethics. So remember that you must actually stick by this code of ethics. If you contravene any of these things which I've already mentioned in the previous slide, you are found in breach of this code of ethics, you're liable to answer to the Health Professions Council. Then the word that many patients actually like to abuse is negligence. There is so much negligence in this hospital, for example. Remember what negligence is doing something that you're not supposed to do or failing to do something that you're supposed to do. Which is why I always urge my students on the ward, please guys, study as much as possible. Make the mistakes now when you're a student because you don't have any responsibility. You don't have any patients' lives in your hands. When you now become a doctor, you make a mistake or you fail to do something, you're incompetent, you'll be judged and you'll be taken to court, you'll be held accountable. So remember that in terms of professional negligence, the absence of reasonable care and skill or willful negligence of a medical practitioner in the treatment of a patient, which is going to be directly resulting in bodily injury or death of the patient. You could be held accountable for this. There is civil negligence where you, under these particular conditions, duty, for example, existence of duty of care by the doctor, dereliction where there's failure on part of the doctor to maintain applicable standards, which is why you have to keep revising your information, updating your information, direct causation where there's any damage that was caused by breach of duty, and of course damage itself, which may be as a result of lost wages, medical expenses, or mental duress. So there are some future lectures that I want you guys to look out for. If you enjoyed this particular video as much as I enjoyed teaching it, please comment in the section below, and so that I can do videos on consent, videos on euthanasia, videos on reporting professional misconduct and how to report higher ups, and how to see if you have been unfairly treated at work. And of course, duties of the physician, duties of the patients, duties of the public, your rights as a clinician, the patient's rights, and even lastly, the Health Professions Council. I'll talk about the Act and the different changes that we have actually seen in the Health Professions Act of Zambia changes. If you enjoyed that video, consider subscribing to the channel, hit the bell notification icon so you never miss on such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.